The goal of this presentation is understanding how to recognise tendons and their specific architecture and characteristics when scanning them with ultrasound. Like a muscle, the tendon has different parts. The three smallest parts are the bundles, with the primary bundles being the smallest of the three and the tertiary bundle being the biggest of the three. The primary bundles are assembled to form secondary bundles, which are clustered in tertiary bundles. Endotenon is a thin connective strip surrounding the primary, secondary and tertiary bundles and separating them. Vessels and nerves run within the endotenon thickness. All tertiary bundles together form the whole tendon. The epitenon is a stronger connective tissue covering compared to the endotenon and surrounding the whole tendon. Knowing this tendon anatomy and being able to recognise the different parts is important for tendon pathology recognition. In longitudinal ultrasound views, the tendons appear as echoic ribbon-like bands defined by a marginal hyperechoic line corresponding to the paratenon and characterised by a fibrillar internal structure. In transverse views, tendons appear as round or oval-shaped structures, characterised by several homogeneously scattered spots or pixels. The density of the hyperechoic fibres or pixels give the whole tendon a more hyperechoic colour. This is the most important slide of the whole ultrasound, so pay attention now. Make sure you always scan all anatomical tissues, but especially tendons, perpendicularly, which means under a 90-degree angle on the fibre orientation. Let me explain why. Here you can see the quadriceps tendon inserting to the patella bone and retinaculum. Do you see the hypoechoic zone and the quadriceps tendon near its insertion next to the patella? A white asterisk symbol is indicating this hypoechoic zone. Such a dark zone inside a tendon could definitely be pathology, for example, a partial tear, but in this case it's not. It's an example of an artefact. Artefacts can be defined as any structure in an ultrasound image that does not have a corresponding anatomic tissue structure. So actually a ghost image. Artefacts are a common occurrence in an ultrasound display, since they are often the result of the physical properties of ultrasound itself. You will learn more about artefacts in a presentation in the Basic Level 1 course. Recognising artefacts is essential to proper ultrasound interpretation, as not identifying an artefact leads to misinterpretation. The artefact in this image is called anisotropy. Anisotropy means that during an ultrasound exam you don't see an anatomical tissue which is actually there. Because it's a very important message, I will repeat it once again. Anisotropy means that you do not see an anatomical tissue which is actually there. The hypoechoic zone inside the tendon in this image is a ghost image, mimicking pathology, but the tendon fibres are healthy and all present. So how does anisotropy exist? The transducer produces the ultrasound beam which travels through various soft tissue layers. The ultrasound beam hits the patella bone, which in this case has an oblique orientation. The ultrasound beam does not hit the bone perpendicularly due to the angle of the patella bone. The result is that the ultrasound beam is not being reflected back to the transducer, but reflected away from the transducer. The angle of incidence is the same as the angle of reflection. The result is that, partly due to the unreflecting ultrasound beam, some information misses. The ultrasound does not see this zone. To solve this situation and to avoid anisotropy, one should move the transducer in a way that the angle of incidence is perpendicular to the scanned tissue. After which, the ultrasound beam reflects back to the transducer and all information is processed by the system. This image shows how magnified tendon tissue looks in a relaxed state. Do you see the wavy appearance of the tendon? This wavy appearance allows the tendon to stretch during movements. But on micro level, you see that due to the curved fibres, it's hard to scan a relaxed tendon fully perpendicular. The angle of incidence is the same as the angle of reflection. As a result, anisotropy on micro level can occur, which means that tendons are not correctly visualised. To avoid this anisotropy in tendons, we always scan tendons with a little bit of stretch. With this stretch, the wavy appearance of the tendon fibres will be straightened, and a perpendicular ultrasound scan is guaranteed. In this image, you'll see 3 tendon types schematically and with the corresponding ultrasound image underneath. Type 1 on the left is a tendon invested by paratonon. Type 2 in the middle is a tendon invested by synovial sheath. Type 3 on the right is an example of the flexor digitorum tendons of the fingers. It shows the normal appearance of an annular pulley and retinaculum, which prevents bowstringing of the underlying tendons during flexion of the fingers. Note that the superficial portion of the pulleys has a hyperechoic fibrillar appearance due to the perpendicular incidence of the ultrasound beam, whereas its lateral portions are hypoechoic as a result of anisotropy. A lot of tendons have avascular zones, zones with less blood flow. In a perfect healthy tendon, these avascular zones can't be seen with ultrasound. However, it's good to know as many avascular zones as you can, as these zones are special regions of interest. They are weak spots in a tendon and more prone to degeneration and pathology, so you should check these spots thoroughly. In this slide, you can see the avascular zone of the supraspinatus, indicated with the capital A. It's exactly this spot where you can find the most supraspinatus tears, here indicated with the black pin. In this image, you can see the avascular zone of the Achilles tendon, indicated in green. The midsection of the Achilles tendon is markedly more hypovascular than the rest of the tendon. 80% of Achilles tendon ruptures occur within this region. With the avascular zones of the supraspinatus and Achilles tendon, I showed you 2 examples of many known avascular zones in tendons. If scanning a tendon, make sure that the patient is in a comfortable, relaxed position with the tendon slightly on stretch. The transducer should be placed on the skin perpendicularly to the tissue and with only a slight pressure. More information can be read on this slide. Please click the pause button to read all information.